All right, let's go to the next speaker and to conclude the session, the management of atrial fibrillation and PCI. I would love to invite Dr. Hussein Heshmat. غني عن التعريف ما شاء الله. He is a professor of cardiology from Cairo University and intervention cardiologist residing and working in the United Arab Emirates.
Thank you, Dr. Khaled, for the kind introduction. I'm glad to be here in the GIS for the 4th year. And I'll be talking briefly about a relatively not uncommon situation that we face, which is atrial fibrillation and PCI. And there's lots of evidence, but the number of scenarios and possible permutations that we have far exceed what any guideline can encompass. So I'll try to cover what's the incidence, what's the risk, and how should we manage, with a touch on rate control versus rhythm control, and then what to do about anticoagulation, which anticoagulant, dual, triple, when to start, when to shift from triple to dual, and how long to continue therapy. So atrial fibrillation, patients with atrial fibrillation are usually sick, so the chances of having some form of coronary disease is like 20 to 30%. Among patients who have PCI, roughly 10% of them would have a form of atrial fibrillation. So the population, if you look into the real world, is not trivial. So what to do about these patients? We'll try to answer quickly the electrophysiologic part. Is it rate control versus rhythm control? And the same concepts that apply to AFib in the non-PCI apply also to AFib in the PCI. Rate control has been the preferred, but now there are trials, especially on ablation, that pendulum is shifting a bit towards rhythm control, but we'll discuss more on that. And ablation is coming on the rise, especially in patients with heart failure. Now we have data that it can improve morbidity and mortality. So who's the best who's the best candidate for rate control? Those who are asymptomatic, those who are long-standing atrial fibrillation with a dilated left atrium. Who's the best candidate for electric cardioversion? Those who are very symptomatic and the atrial fibrillation has been there for less than 48 hours, or you can do a transesophageal echo. Antiarrhythmic medications or ablation, antiarrhythmic medications for the young, for patients with heart failure, or when they fail the rate control. Ablation is the best for younger patients, those who need the best quality of life, or those who have heart failure because it might have an impact on morbidity and mortality. And now let's jump into the real dilemma, which is balancing the risk of thrombosis and bleeding. And atrial fibrillation increases the risk of thrombosis and stroke. Acute coronary syndromes and PCI also increases the risk of stroke. When we handle PCI patients with dual antiplatelet therapy, then there is a risk of bleeding. When we give anticoagulants, whether vitamin K, non-vitamin K, we also increase the risk of bleeding. So the question is, how can we balance the risk of thrombosis and the risk of bleeding? Looking at PCI itself, we've all done PCI. We have all experts here, and we know that stroke is there whenever we do angiography, in post-CABG, in an hostile aorta, and the risk is higher in those who are hypertensive with history of previous stroke and those who use intra-aortic balloon. So PCI on its own is a risk for stroke. And the more drugs we give to handle atrial fibrillation and PCI, then we increase the risk of bleeding. If we give triple therapy, then the risk of bleeding is 5 times. It's 5 times compared to placebo. And we know from long time ago that bleeding is not just a hemoglobin drop. Bleeding is not just a blood transfusion. Bleeding is equivalent to mortality for many reasons, because we might have to stop antiplatelets. Transfusion is hazardous. These patients are frail. So bleeding should be regarded as a notorious situation that we should try to avoid. So I will bring you what the guidelines say, particularly on this situation of atrial fibrillation and PCI, the latest ERA guidelines of 2021. And let's take the journey from the beginning. Someone who's going for PCI and he's already taking an anticoagulant. There is a big divide whether it's an elective PCI and chronic coronary syndromes. So in these patients, it's better to stop the novel anticoagulants, preferably more than 24 hours before the procedure. And for some reason, the guidelines give priority to coronary bypass or balloon angioplasty. In the contemporary practice, of course, it would be drug-coated balloons. They are on the rise. We need to give anticoagulation as the usual, unfractionated heparin, avoid 2B3A blockers, and of course, when we give the stents, we need to go for the highest generation, and there is no point at all anymore in bare metal stents, because we know that the rates of stent thrombosis on the long term would be more than drug-eluting stents. So that's in the elective situation. In the emergency situation, it's a bit different. In a STEMI, then of course there's no chance to stop. We have to go directly to the cath lab. Radial access is preferred. Newer generation drug-eluting stents. We need to give unfractionated heparin regardless of any novel anticoagulant. Avoid 2B3A blockers because the risk of bleeding, of course, would be high. It's good to avoid fibrinolytic therapy in these situations. And then the question, the PCI is done. We are done with heparin, low molecular weight heparin or whatever, so we need to start an anticoagulant. Shall we give triple or dual therapy? And let's take it back since the days of warfarin, and even now, we still have patients who need warfarin, patients with mechanical valves, patients with rheumatic mitral stenosis, patients with antiphospholipid syndrome, and we know from a small study, the WOST study, that dual therapy with warfarin, clopidogrel is better than triple therapy with warfarin, clopidogrel, and aspirin. And this finding has been replicated in other observational trials, that death MI is not different, but major bleeding is less with dual therapy. And then came the era of novel anticoagulants. And we are lucky that we have good data for the 4 agents. Different study designs, but they have a common theme, which is there's always a a P2Y12 inhibitor. And the question is, triple therapy with warfarin versus dual therapy with a novel anticoagulant plus a P2Y12 inhibitor. And to me, I am slightly inclined to the data of dabigatran from the ReDual, because it's the only one which used the 2 doses and they were randomized. So they have data for the 150 and they have data for the 110. And in both cases, they were better than warfarin in terms of bleeding. We still have good data from other people, but for rivaroxaban, the trial included a 2.5 milligram dose, which is not an AFib dose, but still it can be used. Data from apixaban are also good. Apixaban plus P2Y12 when it comes to bleeding is better than warfarin triple therapy, including aspirin. Looking at edoxaban, they also have the same set of data. If we exclude the first 2 weeks, then there's still a significant benefit in terms of bleeding. And the dose reduction that applies for PCI is the same that applies for other situations of atrial fibrillation. And then there's good meta-analysis that tells us what happens in terms of bleeding and what happens in terms of mortality. And there will be some findings that are noteworthy. First, if we look at any criterion of bleeding, International Society of Thrombosis, clinically relevant major bleeding, then it's of course in favor of NOACs, dual therapy compared to warfarin triple therapy. The same applies to any form of bleeding. But we know that bleeding is risky and it's associated with mortality. But why here, although we reduced bleeding, the cardiovascular death is the same? So there must be something that's unexplained yet. And it could be in the risk of myocardial infarction. There is a slight, it barely missed the statistical significance, but it seems to be there. There is a slight increase in the risk of stent thrombosis, and there is a slight increase in the risk of myocardial infarction when we go for dual therapy with NOAC plus P2Y12 compared to vitamin K antagonist triple therapy. So we need to keep this in mind. And this is the document from the guidelines. We can discuss a whole lecture just on this slide. But looking at the upper row for elective PCI, then triple therapy is shortened just to 1 week. Then for 6 months, it's dual therapy based on the trials. And after 6 months, we continue just on a novel anticoagulant. And this figure illustrates why guidelines are just guidelines. They are not the law. They should not dictate your practice and what to do, because there will be dozens of situations that we cannot encompass here. A patient with recurrent stent thrombosis and a low SHAD score, a patient with high SHAD score and high bleeding risk. So, but if we stick to the guidelines for patients with ACS, then the duration of triple therapy is probably between 1 week and 1 month. And I'd like to keep in mind that most of the trials of NOACs, some of them randomize patients after 10 days. So there might be a period that was unaccounted for in the initial design of the trial. So looking back to the guidelines, triple therapy for a duration between 1 week and 1 month. Then, of course, between 6 months and 12 months for ACS, it has to be dual therapy. After 1 year, usually the threshold to omit the dual antiplatelets should be low. We also have some data that if we combine single antiplatelet with rivaroxaban, after 1 year, there will be an increase in mortality. The last question, is it clopidogrel or ticagrelor? We don't have enough statistical power from the trials to tell us this answer. There was no randomization. But if you are worried about stent thrombosis, left main, long segment of stents, more than 30 millimeters, repeat procedures, then the statistical data shows that the benefit in terms of bleeding reduction is still preserved even if you use ticagrelor. But of course, the biggest evidence is for clopidogrel. So we discussed briefly rate control versus rhythm control, triple therapy versus dual therapy. Risk of bleeding is markedly reduced by NOAC dual therapy, but keep in mind there is a slight increase in stent thrombosis and MI. Thank you so much.
Thank you, Dr. Hussien. If we have any question from the audience.
I have a question.
Yes.
The current trend is to use less triple therapy in patients with atrial fibrillation. My question is, if you have a patient who you plan to give a worst approach, clopidogrel and NOAC, or clopidogrel or Coumadin, don't you think that even if there are no dedicated studies, make sense to evaluate the responsiveness of clopidogrel? I will feel very worried to give only clopidogrel if I have a test, you can do verify now, whatever, and see that he has zero responsiveness of clopidogrel.
Yes, of course, that's an expert opinion from the dual antiplatelet therapy. Yeah, of course. Verify now is available and it can be used, but again, it still remains as an expert opinion. It's not in the AFib arena. There's no special trial up till now that looked into verify now into the atrial fibrillation patient. But again, even if we use ticagrelor, the benefit that we get in terms of bleeding reduction is there. So if you're worried about stent thrombosis or clopidogrel response, then it would be ticagrelor.
We have one more question from the audience.
Nice presentation. You see, this topic is a very hot topic for a long time. You see, I will claim that all trials, which was nicely mentioned, they are seriously underpowered for a thrombotic event. So I think we have to remember this. Majority of all these trials were looking into the incidence of bleeding. And they put lower interest into the thrombotics. So I think my first message is these are seriously underpowered for thrombotic. The second point is when it comes to thrombotic scoring system and bleeding scoring system in this patient, the correlation between event and thrombotic score is high. So this means if it's high thrombotic, there will be high event. But the correlation between bleeding and event is intermediate. So if there is a high bleeding risk score, the incidence of bleeding will be 50. But if there is a high thrombotic score, it will be 90. I don't feel comfortable in just dropping antiplatelet for possible anticipated bleeding, while I know that the thrombotic risk is very high. So it's a word of caution.
Yeah, maybe there is, the discussion will be after the second lecture. Maybe the
Yeah.
second talk,
Second
we'll talk
talk,
about
yeah.
the same thing.
Thank you, sir.
All right. Thanks, everybody. I think we should move to the next session, chairing by Dr. Musa Akbar. Thanks all. I thank the panel and the speaker. Thank you.